Okay, this is going to be a trauma assessment walkthrough. I have Evan here. He was hit by a car while riding his bike. Um, he's got a flailed chest and a left tib fib injury, and some not okay breathing. When you're doing your patient assessments or trauma assessments, just like your medical, we start off the same way, right? BSI, seen and safe. You've got one patient. NOI is going to be, or MOI is going to be auto versus PED. Call for additional resources. Consider ceasefire and precautions. I want you guys to actually decide whether you're going to take it or not. We can always change it, right? General impression, he's unresponsive, doesn't seem to be alert as you walk up. You're getting kind of more vocal, getting a little bit hands-on. He's not responding to that at all. Do a painful sternum rub or a trap pinch. See if that elicits any emotion or expression or response. It doesn't. He's now unresponsive. So we're going to get down there, look, listen, and feel. Check for breathing, check for pulse. If it's not obvious, that is, right? Sometimes it's a lot more obvious and we don't need to get down that low. At this point, we'd have somebody come in if we needed to and start bagging their patient, ventilating for us, controlling that respirations if it was irregular, short and shallow, and rapid, or very slow, or maybe absent. Okay. This would also be the time where if you find a major bleed, a life-threatening bleed, you would control that, right? Go through your ABCs. We've got breathing under control. Maybe, give him some oxygen if needed, checking for those pulses, checking shock treatment, going through that whole shebang of, just like in medical with your ABCs. At this point, transport decision. Are they going to be rapid? Are they going to be, stay and play? Kind of depends on what's going on. Evan being unresponsive, probably load and go, right? Get him out as soon as we can and monitor those respirations, ventilate for him if needed, and go from there. Taking a full set of vital signs, pulse, blood pressure, respirations, monitoring for shock, making sure that we're not trending in that direction, asking a bystander or a family member for a sample or history questions, getting whatever information we can before we leave scene. That's only going to help us in the long run. At this point, we're going to do our big head-to-toe assessment, starting at the head, going down the body, looking for any other injuries, anything that we may have missed, looking for broken bones, that decap BTLS, head-to-toe, deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, swelling, okay, all those different things. We're going to start at the head, working our way down the body, looking for any bleeding, feeling for soft spots or any crepitus, back of the neck, looking for any step-offs or tenderness, okay, JVD or tracheal deviation in the front of the neck, going back up, eyes, forehead, nasal bone, inside the mouth for any broken teeth, blood lacerations, behind the ears for any battle signs, or fluid, cerebral spinal fluid coming out of the ears or the nose isn't a good thing, right? That's head trauma related. Put a C-collar on if we need to, start working our way down. Doing shoulders, clavicles, looking for any give, looking for any pain response as we do this. Sternum compression, hands together, doing one solid compression down the center of the sternum, looking for any give or mobility there. Ribs, compressing them, making sure they're equal and bilateral. They're coming in and out. He's breathing. He's got good chest rise and fall. Obviously being cautious with his left side for this patient because of the injury. Looking at the abdomen here, realizing that it starts up higher than it normally would, doing a rolling motion like this. All right, we're not just poking him. We're doing a more rolling, palpating motion. All four quadrants, looking for guarding, rigidity, distension, pain, rebound or tenderness, anything that can indicate bleeding, or ruptured or damaged organs on the inside there, right? Looking at the pelvis, we're going to compress down and in, okay? Looking for any give. We're not going to rock. We're not going to do that. Just down and in, looking for stability. Genitalia as needed. If we need to look at it, we're concerned about it, we'll take a look. Otherwise, we're not going to go there. Both legs, we're going to go inside low, outside high. Right, getting circumferential pressure, looking for, once again, crepitus, decap BCLS, looking for give, broken bones. This is when we'd find that left tib fib injury right there, where we would now bandage that and splint it up and manage that injury. Checking for pulses, down low, having them push, gas pedals, push up, pull down, PMS in both extremities, doing this at the exact same time. Going up, doing the arms, left and right, going all the way down, making sure we get that wrist in there, some of the hand. Okay. Bringing both of them up and checking for pulses. And once again, PMS, so pulses, motor, squeeze my fingers, and checking for any response. I know Evan is unresponsive, but I'm still going to check for PMS in all 4 extremities. This is where you might get a response back, and it might tell you that he's regaining some sort of consciousness, which is a good sign of leading towards improvement, right? So it's also a great way of just checking overall quality of patient. At this point, we'd roll the patient over. We'd have our head person holding C-spine precautions. We'd roll them towards us on the head's count of 3. 1, 2, 3. We would then palpate the back of the spine, doing each little vertebrae, looking for step-offs, pain. We're going to check, the flanks, the buttocks here, making sure we have no fluid, bruising, things like that, back of the legs. We would then insert a backboard if that's what we were going to do, and roll him down onto it. Strap him down and whatnot. From there, we're pretty much done. We'd transport to the appropriate facility, and we would continue to monitor our patient every 5 minutes. Vital signs, interventions, being bandaging and airway, making sure everything that we've done for this patient is improving and staying the same, right?